Have you all joining. We're going to record this in case people can't make it. So Dr. Tony DeFrance here. I'm an interventional cardiologist and the Vice President of Clinical Affairs for Cleerly. So we're going to talk today about coverage and payment updates for plaque or AI-QCT and ischemia analysis. We have some experts on the line. And so this should be a good discussion. Please uh, pose questions as we go through, and we'll go through towards the end of this and answer all your questions. So I'm going to start with just a couple slides. I'm going to keep my part brief because we really want to hear from the experts on reimbursement on the call. And you know, some of these slides are pretty obvious stuff for those of you, especially cardiologists or other clinicians, but you know, the scope of heart disease is huge, and unseen plaque progression, especially high risk soft plaque or non-calcified plaque, drives many of the sudden cardiac events. And we have almost 1 million Americans dying every year of heart disease, and greater than 50% of individuals who die or suffer from a heart attack experience no symptoms before the event. And we still have about 400,000 to 500,000 sudden deaths a year in the US, and the majority of those are related to coronary atherosclerosis. So although, you know, we're going to talk a lot about symptomatic use of these technologies, there's a real push in the future, hopefully, towards asymptomatic analysis of coronary artery disease and high-risk plaque. So obviously, atherosclerosis is the critical component behind all of this. And we're calling it soft plaque in here, but it's really non-calcified or low-density non-calcified plaque in the arteries, silently builds up over time until a sudden major adverse cardiac event. It shouldn't say MACE event, but major adverse cardiac event. And plaque can also lead to ischemia. Also, that further increases the risk of MACE in patients. And really, the fact that we can now quantitate and characterize plaque by phenotype, better identify and monitor patients most at risk. So I'll take you through, again, here's just some of the things I talked about: plaque causing ischemia and major adverse cardiac events. And I think, you know, proxies really aren't enough. And advanced imaging has made great strides in terms of cancer care, as you all know, moving from breast exams to mammography, fecal occult blood to colonoscopy, et cetera. But in cardiac care, we really haven't done that. We use risk factors. But as you all know, many people who have a heart attack don't have most of the classical risk factors, and about 70% have what's considered normal cholesterol. I already mentioned this, but 50% of heart attack victims feel no symptoms before the event, and 75% of heart attack lesions, the lesions that cause the acute MIs, are missed by stress testing because they're typically less than 50% in terms of stenosis. So that's been a revelation over the last couple decades. Sorry, went backwards one. There it is. Okay. So really, our point is, you know, risk factors aren't enough, proxies aren't enough, that using advanced imaging is really, hopefully, the future of how we reduce MACE, major adverse cardiac events. And this just shows some images from a Cleerly plaque analysis study. You see the longitudinal stretched out artery there, straightened curved planary format, and then the different types of plaque within this one artery. From left-hand side, the calcified plaque, which we colorize as blue, mixed plaque, which is kind of blue and the yellow, the second one from the left, more non-calcified plaque predominantly in the third picture and fourth picture. And then on the right-hand side, we colorize as red the low density non-calcified plaque. So that's what is often a component of high risk plaque, the ones that are more vulnerable to rupture. So those have lower Hounsfield unit densities that make up those plaques. So we really can look at the kind of phenotype of this plaque and see and understand which plaques are, you know, have potential to cause clinical events. So Cleerly is the first non-invasive tool that you see and monitor high-risk soft or non-calcified plaque. And just briefly on this one, we're looking at area under the curve for major adverse cardiac event. You know, how do we predict this? And typically we've used different kinds of risk scores, risk factors, Framingham, ASCVD scores. And you can see, looking at 2, 5, and 10 years, the risk scores are okay, but just, above 50%. You add calcium scores to that in the second line, that improves it some. You add the Cleerly stenosis measurements, improves it more. But then if you add the atherosclerosis quantitation measurements, plaque characterizations, you get very good predictive ability for MACE. And this just shows, this is from one of the components of Cleerly. This is our kind of workstation. We call it Cleerly Labs. This is where you can go in and rotate the arteries and zoom in more detail. But it's really end-to-end AI for coronary disease. So we look at atherosclerosis, as I've told you, that volume, composition, length, location of lesions, the stenosis percentage in 2D, 3D. And then ischemia, we use AI machine learning to determine how likely it is that a particular lesion or an artery would be ischemic. And this next slide shows, one of the things that we've done a ton of research. Cleerly is founded by, trialists Jim Min, Udo Hoffman. And one of the things that they've looked at is kind of looking at staging plaque, finding different degrees of atherosclerosis from no plaque, 0, to mild plaque up to 250 cubic millimeters, moderate plaque or stage 3, as we call it, is 250 to 750, and severe plaque greater than 750. And these correlate with outcomes too, with very high MACE outcomes, and mortality findings with these very high risk, more severe amounts of plaque that we can see. And it's not just put them on a statin anymore. Now we have a whole range of treatments and targets to effectively treat atherosclerosis, with a more precision approach. And we have a large trial called the Transform trial going on, looking at using these various agents according to stage of disease in asymptomatic patients. And this just zooms in a little, showing you a little more. On the left-hand side is the platform. On the right-hand side is the plaque we can see there. And again, I told you the yellow and the red. Yellow is non-calcified. The red is the low-density non-calcified. So this would be a high-risk plaque, even though it might not be a severe stenosis. I'm eyeballing it at about 50%. But this is the type of plaque that is prone to rupture and high risk. So. And you can see all the quantitation we have on the left-hand side, looking at the types of plaque, the lengths of the lesion, et cetera. This is the ischemia product, briefly looking at how Cleerly does it. We don't do computational fluid dynamics. We've used AI to determine multiple factors that make it likely or unlikely that ischemia exists. And even in an artery like this with multiple stenoses, it will go through and identify lesion 1 up here, 76%. That's the one highlighted on the right in the quantitation. You can see the length of the plaque, the volume of the plaque. And, really we're looking at, it's like using several different invasive modalities. QCA gives you the percentage. We get the length of the lesion like IVUS, the minimal luminal diameter like OCT, and even the plaque composition like NIR. So it's a very powerful tool. And in this case, ischemia was determined likely. And then we output it, right? You got to take the data. It's outputted in text reports. If readers want to use it like that, it's also outputted more graphically for possibly clinicians or end users. It's also outputted in this third interactive reporting format that people have access to. And so this is the last slide. We just wanted to point out that Cleerly's really helped lead the way, both in science and in the advancement of the CPT codes, which you're going to hear about now. We submitted the application in June of 2024 to the AMA CPT editorial panel requesting the transition of Category 3 CPT codes, the T codes, which we have, to a Category 1 code. And amazingly enough, somehow the team got it. This is a very rapid turnaround. In September of 2024, the code transition was approved. The panel voted to accept it and moved to a Category 1. So good news there. And that's what the rest of this talk is going to be about. But I just wanted to give you a quick overview of Cleerly. So hopefully I know I blasted through those, but I really wanted to get to our key speakers today. And just the usual disclaimer here. And then I wanted to introduce the two speakers. I'm going to introduce them both briefly, and then Dr. Slim's going to take over, and then he'll hand it over to Alyssa Foster. So Dr. Ahmad Slim is a cardiologist, educator, a veteran currently serving as Chief Medical Officer of Pulse Heart Institute in the Puget Sound region. So the Northwest. He's also an associate professor of medicine at the University of Washington. And from 2003 to 2015, he served in the United States Army as both a cardiologist and field surgeon. Dr. Slim's participated in major clinical trials, authored guidelines on managing heart disease and high-risk occupations, and co-authored impactful studies on team-based care models in preventive cardiology. He serves as chair of the HPP committee for the SCCT, and currently sits on its board of directors and executive committee. So we're going to let Dr. Slim take over in a sec. I'll introduce Alyssa Foster first. She's a reimbursement consultant and partner at Forefront Strategic Partners with 20 years of experience in the industry, the certified professional coder, and has a proven track record in working to secure new codes as well as new technology payments for her clients. Alyssa's authored many coding guidance articles for AAPC magazine, and developed a course for the University of Arizona MBA program with a focus on professional development in the biotechnology industry. So did you stop sharing my screen, or do I need to do that? Let's see. We're going to let Dr. Slim take over here. So Dr. Slim, are you able to share your slides?
Yes. Thank you. Thank you for having me. And I appreciate the kind words in the introduction, and love the introductory slides, Tony. I get the pleasure of talking about a topic that's so exciting that I'm positive a lot of people are happy about, and it's reimbursement and coverage as it relates to plaque and really CTA overall. Hopefully, you can see my slides. There is a few second delay as we transition.
Dr. Slim, we need the full screen, please.
It should be on full screen. I can try and do it again. Apologize. Can you see it now?
It's still, yep, we see it now. Thank you.
No problem. So again, minor delays. But when we do look at healthcare, what we're trying to do really is balance a lot of things on a pyramid. We have AUC's guidelines and randomized clinical trials guiding the way, and healthcare policies being the place where we balance both the consumer, the patient, the clinical benefit, both in the short and the long term, as well as insurance carriers, direct payments, government, and value-based care with cost balance in the long run. And to be able to achieve that, we have a triad of things that most of the time physicians, we do confuse them. And that's healthcare policies, coverage, and reimbursement. For us on the front line, we think of them as interchangeable when they really are not interchangeable. Healthcare policies are policies set by payers across the platform, and the platform could be nationwide. And it's just simply no different than a guideline that's provided to the regions as what should be covered. However, that is a guideline in a way. It is not a mandatory application of the policy. Each region, and there are different regions depending on the payer. So, for example, for Medicare CMS, the region that I reside in the Pacific Northwest is Noridian. That's the administrator for that region. And that region determines the coverage based on that policy. They interpret the policy differently, and each region will have criteria for coverage. Now, interchangeably, we assume on a provider side that if there is coverage, then we are getting reimbursed. Unfortunately, that is not true. Just the presence of coverage does not translate to reimbursement. There are always nuances that determines that. So a perfect example, if you order ischemia or flow, and you link it to a different ICD-10 than what the coverage is linked to, there is no associated reimbursement and you will not get paid for the services. A perfect example is using R93.1 to be able to link it up to ischemia. And if you link it to CAD, it will not be approved. Simple things as shortness of breath or dyspnea, they're interchangeable in our world, but for the payer, there are payers that if the condition is listed as dyspnea, they will not reimburse for stress testing as opposed to shortness of breath. So these are the nuances as it relates to coverage and reimbursement. The presence of coverage does not guarantee reimbursement. There are certain steps that has to be followed within the coverage policy for reimbursement to follow. So this has always been a perplexing topic for me going through GME and then as a young attending. Anytime that people talked about CPT codes or E&M, I just thought there are gods in the sky that just dropped them and somehow I just needed to use them and I had no clue what the process were and it was extremely confusing. So I would like to spend a little bit of time trying to demystify it as much as I can. The CPT codes, E&M, which is what we use for our visits, all of these metrics are generated by a terminology committee that resides within the AMA. And that's what we call the CPT committee, Current Procedural Terminology Committee. It is the committee that generates the codes that we utilize every day for procedures and the E&Ms that we utilize for our clinic visits. When we do have a new technology coming along, let's take Cleerly ISCHEMIA product and plaque analysis. The first step for any new technology is research. We still don't have FDA approval. We need to assess the validity of it. So we go through the research process. Once we go beyond research and we have FDA approval, that does not mean that it can automatically create a Category 1 code or what we call a Category 1 code that we're all familiar with. It actually falls within what we call the HCPCS process or Healthcare Common Procedure Coding System. This system is designed for pass-through cost. So when you do a stress test, when you use adenosine, that's a pass-through cost. You get a bill for it, and that bill automatically goes to the vendor for the cost of that service. There is no provider component associated with it, and you don't get reimbursed for these services or for your time associated with it. So for any newer technology that does not have any specific code, it becomes a pass-through cost initially. And a lot of places, especially in academic center, that's one way to launch the product till we get to a point where we have enough clinical trials that we are able to get what we call a Category 3 code or a temporary code. And that's the code that we utilize to track the procedure. And in some places, the provider time is compensated for. There are places that does not compensate for provider time unless you are in a Category 1 code. So that allows us to track it. That allows us to assess its utility within the nation and different payers. So what is the hurdle that gets us from what we call a Category 3 to Category 1? Now, keep in mind, both Category 3 and Category 1, they have similar structure. We have 3 codes primarily that we care about. There is a physician code or what we call the work review, and that's the component where we get reimbursed for our services. There's the technical code, and that's the services of the vendor, of the technicians that are working on it. Pretty much covers everything technical beyond the expertise and the time of the provider assigned to it. And in some places, when the same entity does both, the physician and the technical component, they just submit a single code, the global code, and the division is done in the back end. So to circle back, so how do we go from Category 3 to Category 1? That's the code that we care about because that's the one that we're guaranteed to be reimbursed for our work review as physicians and for the technical fees to cover the vendor services and all of our costs. There are 2 thresholds that has to be overcome for us to move from temporary code or Category 3 code to Category 1. One is widespread utilization. Widespread utilization is not an exact formula, unfortunately. The more prevalent the disease, the higher the bar. So if you're dealing with cardiovascular disease, the bar is really high. We're talking about thousands and thousands of patients to be able to document widespread utilization. Versus if you're talking about, for example, ophthalmology trials, then the bar is really low because the threshold is much lower for the population. At least 5 published criteria as it relates to randomized clinical trials, guideline-based environment to support that move. And these are initial threshold criteria for us to move from category 3 to category 1. But majority of the time, if we do have FDA approval, widespread utilization, published data, it makes it so much easier because then the societies can support it when it goes to the CPT panel, and it makes the process very smooth and supported. And that's what Dr. DeFrance was highlighting earlier, is that it was fast to go from category 3 to category 1, just simply because of the robust data and the support for ischemia and for plaque analysis from all societies, versus the average that we do see for emerging technology is somewhere between 3 to 5 years to go from category 3 to category 1. So do we think that we're done? Unfortunately, we're not. So even if we get a category 1, that's not the end of the story. It just simply gives us the codes, but it doesn't give us a way for us to assign work RVUs for it. So how do we get paid as providers for our time? Again, it's not a random process, but it's not a publicized process. Right after we're done with the CPT panel, it goes to another committee called the RUC committee. And the reason that we use the word RUC is because what it stands for is really long. Resource-Based Relative Value Scale Update Committee. It's a mouthful, so we stick with the RUC. What the RUC committee does is it assesses how much time is taken to do the procedure based on submitted reports, as well as primarily driven by something called surveys. The RUC committee will send directed surveys to folks that utilize the technology, and they will give them a spread of similar technologies that is already approved, and we know exactly the RVUs associated with it and the time associated with it, and the provider is supposed to scale it based on that survey. This is great if the provider understands the purpose of it. Majority of the time, the recipients don't understand the purpose of it. What we're trying to assess is the most likely scenario that you see. So that means for the majority of the time when you are doing the procedure, more than 50% of the time, what is the typical time that you do? And for a lot of folks, when they get it, they assume it's an assumption of how good they are as operators. So they always remember the quickest procedure that they've done because they think of it as a way to advertise their institution and not understand the purpose of it. So we always end up with some form of underrepresentation of the provider time. So if you do get the survey, the key component in that survey is do not over or underestimate. Please be accurate and just report it as it relates to more than 50% of the time allocated for it. Not your fastest procedures, not your slowest, but your typical case and your average. Once the RUC committee does that and we have the data, it comes back, and that's not the end of it, unfortunately. Then the AMA RUC committee advises CMS, and CMS will make the final decision and determination. That's usually around November, December timeframe, and most payers will follow suit with whatever CMS lands on. And that's how we end up with what you know as a category 1 and the allocated time and resources as it relates to it. And of course, hustle, rinse, and repeat. And if you're a big society, then we're doing this on quarterly basis with tons of procedure codes that comes along, and that can get overwhelming at times. Now, to complicate things for you even more, just the fact that CMS endorsed it and published it doesn't mean you're going to get paid the same amount of money in whatever environment you operate within. There are 2 separate environments that CMS reimburse for. One is pure ambulatory environment in a physician office, in an environment that's managed by private practice, and this is what we call the Medicare Physician Fee Schedule, or MPFS, if you've ever heard that abbreviation. And if you're really bored at night and want to know how that equation is calculated, I've added the equation at the bottom of the slide. But to simplify it, what CMS does is they look at the work RVU that's allocated for the physician, the practice expense, which is what we call the technical component, and a professional liability insurance. and then they multiply that for geographic practice cost index for each component. And that's really this complex equation is pretty much your work RVU plus your practice expense plus your insurance multiplied by the geographic practice cost index. This is a great equation if the total RVU is compensated at a fair market value. However, in that case, we get reimbursed at CMS conversion factor. So this gets multiplied by that conversion factor. And most of the time, the CMS conversion factor is about half of what it is for private payers. So this complex equation, even though it's fair, it always leads to underrepresentation and underpayment. And most of the time, up to recently, every year we anticipate somewhere between 2 to 3% reduction in that conversion factor, and that equation continues. On the hospital side, and on the hospital side, there are practices out there that are hospital owned, that they perform ambulatory procedure. They don't get paid from the MPFS, they get paid from OPPS or from outpatient prospective payment system. And this came into play in 2000 to regulate the payment as it relates to hospital-based environment, because ambulatory cases in the past that were done in a hospital-based environment, they were getting reimbursed at a really high rate as if you were hospitalized in the system. So this allows for payment, still accounting for facility fees and higher cost that comes with running it in a hospital-based environment, but still has its downfalls. And a perfect example of that downfall is these payments are done under the ambulatory payment classification, and that's the category for which your test falls. And a perfect example is cardiac CT. Cardiac CT fell in an APC that's purely radiology based. So it was getting average with simple chest CT that reimburses at an extremely low rate, and it does not account for the complexity of the procedure itself that it's done in. So when you were looking at cardiac CT being done in OPPS, it was half the value of the Medicare physician fee schedule, disincentivizing places to perform it because it was not even covering the cost of performing the test. Through a lot of advocacy effort within SCCT, we were able to work with CMS, and we reallocated temporarily cardiac CT to an APC that falls within cardiology, where other tests are being done at higher complexity, and that got CCTA to be reimbursed at twice what it was getting reimbursed prior. Now, I use the word temporary because CMS is monitoring its utility, and they need to see in the next 3 years more than 50% utility to keep it in that APC. So this is when we count on folks and locations to be able to engage with revenue cycle within their hospitals and make sure that the services are billed in cardiology APC. It does not affect whether it's done in radiology or cardiology. The reallocation is done in the back end. This is just purely for billing purposes. And I've engaged with my system. It took 3 to 6 months to make the change, but it was well worth it because it covers 11 hospitals and it can make a big difference for that journey. When we look at 2026, there were significant changes that happened in 2026 in the CMS release. And I just wanted to touch base on it a little bit because these are not things that happened before, and it can impact our trajectory and what will happen to reimbursement in the long run. Some of these changes were driven by the Big Beautiful Bill when it was published. When the Big Beautiful Bill was published, it required a 2.5% statutory increase in payment and the conversion factor. So you will see that there's a base of 2.5% increase that came with the Big Beautiful Bill. However, it's not all good news. But before I get to the not so good news, the good news is there was an increase. And for the first time, we have two conversion factors, not just one. One conversion factor is for AAPM, Advanced Alternative Payment Model. And in short, these are the models where they have contractual agreement and they are at upside and downside and at risk with CMS. Like accountable care organizations, places that uses bundled payments, and comprehensive primary care plus clinics. then they will get paid at a higher rate than folks who are not a part of AAPM. So that will translate to 3.83% for AAPM and a 3.3% for non-AAPM. On average, instead of going down to $32, will be around 33.5, $33.59 for APM and $33.42. So it does sound like it's a big increase, but the margin is really in cents when we talk about it, but it becomes cumulative the more that you do. So how are we paying for that increase? Unfortunately, that increase is supported through something called efficiency adjustment. For proceduralists like ourselves, there will be efficiency adjustment by negative 2.5% cut on annual basis. I'm sorry, on every 3-year basis moving forward. The first cut is coming off of a 5-year look back at what we call the Medicare Efficiency Index, which is an average of that payment. And then we will take a hit of 2.5% reduction for procedures. And this is based on the fact that they assume that we will continuously always have productivity gain and continuously become really fast over time. Now, this is recalculated every 3 years with a 3-year look back. The problem with this equation is if it continues, you're going to get to a point where you are working for free because you keep adding the 2.5% reduction. It's just going to add up over time. So different societies are engaging with CMS on that equation, and we're trying to figure out if there's an end in sight or this is just a perpetual process that will negatively affect productivity, and especially at a time where inflation is rampant. So stay tuned, but this is how the offset is happening for that increase in the conversion factor that we saw earlier. So just to quickly touch base on what we consider coverage, and this is to highlight what I was talking about earlier as it relates to coverage criteria. And we will look at coverage criteria for plaque analysis. These are the criteria that are approved. The patient has acute or stable chest pain with no known CAD and is eligible for CCTA. CTA classifies patients as intermediate risk, or patients has CAD-RADS 1, 2, or 3. CAD-RADS 4 do not qualify for it. Cardiac evaluation is negative or inconclusive for acute coronary syndrome. This is the coverage component of it, but you have to always keep in mind the exclusion criteria that will affect your reimbursement. If you're not cognizant of the exclusion criteria, you will walk into the trap where you have coverage, but you end up with no reimbursement. And this is the list of all the exclusions. In the absence of signs and symptoms, that cannot be done for screening, where there is contraindication to CCTA, because of course you need CCTA as a base, CAD-RADS 0, or CAD-RADS 4 or 5, or more than 70% stenosis or an MI within 30 days. So the list goes on. So these are the things that affect your reimbursement. So I mentioned the coverage and the reimbursement, and you ensuring that you are aware of the exclusion criteria supports you on the reimbursement side. I know this was a very dense and packed topic, and hopefully I was able to demystify or simplify some of it. This is not something that we're always excited to learn about and adjust, but I appreciate the time and the opportunity to talk to you about it. And without further ado, I'll pass it on to Alyssa.
Perfect. Thank you, Dr. Slim. I'm just going to share my slides. Give me one moment. Okay. You can see that. Okay, give me. Perfect. Okay, so Dr. Slim got into a lot of really great detail and process and how policy and reimbursement works. I'm going to talk more specifically about the codes that are used to bill for Cleerly, and a little bit about the coverage updates as well. Forgive me for a little delay in the slide advancement. So this is just our standard disclaimer. Again, we're going to go over some coding updates, some coverage changes, what's changed and what you need to know. So starting with coding. So as Dr. Slim mentioned, Cleerly went through the very long and tedious process of first getting a Category 3 code and then transitioning that Category 1 code to that Category 3 code to a permanent Category 1 code, which is a huge accomplishment. So the new code, which became effective on January 1st, 2026, is CPT 75576. And as Dr. Slim mentioned, there is a global payment assigned, and then also that global payment is divided into two payments for the technical component and then the professional component. I did see a question in the chat about payment, so this slide and the next slide will be covering that if you want to take some notes here. I'll also add too that these payment rates are available in the Cleerly coding and billing guide as well, so you have access to that. But again, huge accomplishment to not just get these codes established by AMA CPT, but get them priced through the RUC process and a price that we're very happy with. So again, here are the payments that the physician is reimbursed. I do want to call out the two kind of sections here again that Dr. Slim spoke to, which was payment for physicians who are participating and qualifying under the payment program, as well as physicians who are not. So slight differences in payment here. Okay, and then shifting gears from physician payment to what the hospital outpatient department is paid. See the same code, but the payment reflected here is what, again, the facility that is a hospital outpatient department would be paid. So the physician gets paid one check, if you want to call it that, and then if the procedure is performed in the hospital outpatient department, the hospital outpatient department gets a separate payment, which you'll see is this $950.50. This is all Medicare rates. Actually, before I move on, I also want to address the status indicator column. So the status indicator S is really important to understand in hospital outpatient department payment, and this is also a very good accomplishment from the Cleerly team. This status indicator S here means that this procedure, when billed with other things like a CCTA, would not be discounted due to multiple procedure discounting or packaging rules. So again, we really are happy to see this, and this has very positive implications to the facility's payment for these services. So let's just talk about diagnosis coding for a second. Again, CPT is related to the procedure. Diagnosis coding is related to the patient's disease, condition, symptoms, and very, very important to support medical necessity and that coverage determination by the payer, again, as Dr. Slim mentioned. So we see R93.1 highlighted here. This is the diagnosis code that Medicare and many commercial payers require on claims to allow coverage for the Cleerly analysis. And then they'll also look for other diagnosis codes. We have a list here in addition to that primary diagnosis code to support coverage as well. So Dr. Slim briefly covered the Medicare criteria, and chest pain is one of those. So reasonable to believe that those payers will also want to see chest pain reported in diagnosis coding on the claim, and then also very important to document those symptoms as well as those diagnoses on the medical record as well. And we talk a lot about Medicare criteria, but obviously commercial payers would have their own policies. Most of them follow Medicare, but it is very important that you are aware of the payers that you commonly bill to see what their policies say and if there is any difference to the Medicare policy. All right, so we're going to leave plaque behind for a minute and talk about ischemia. So The new codes that were published were for plaque. ISCHEMIA had permanent coding already, category 1 coding, 75580, but we just wanted to note the payment rates that had become effective January 1st as well. And these figures are also available under the fee schedules as well as the billing and coding guide. So these are the payment rates again for physicians. And then this slide here is payment for the hospital outpatient department. And again, very pleased that the code has a status indicator of S, which means that when billed with other procedures, it's not packaged. So again, very, very positive for Cleerly and providers who use it. Like we talked about with plaque, this is a list of diagnosis codes that payers want to see to establish medical necessity for ischemia patients. Again, same kind of tip, make sure you're aware of the patient's specific payer's coverage plan and if there are any specific criteria that need to be documented and need to be reflected in the diagnosis code reporting on the claim. All right, so we're going to leave coding behind and talk about coverage. Some of this will be a little bit of a duplication of Dr. Slim's presentation, but again, as he stated, is very, very important because even if you have codes, even if there's established payment rates, if the payer won't cover it, then reimbursement is 0. So again, talking about plaque first, and again, this is duplicative of what Dr. Slim presented, but very important to understand that Medicare does have published coverage for Cleerly. And their criteria is that the patient has, again, documented acute or stable chest pain with no known coronary artery disease, and is eligible for CCTA, but they also want to see documented that the CCTA classifies the patient as intermediate risk or had RADS 1 through 3, and a cardiac evaluation is negative or inconclusive for acute coronary syndrome. So that's what they want to see, again, documented and, if possible, reflected in the diagnosis coding to cover the analysis. And they don't want to see all of the things in the limitations list because that would then disqualify that patient's case for coverage. This is just a slide that provides an overview on what specifically needs to be documented. Very important best practice for reimbursement is if it's not documented, it didn't happen. And claims are always subject to potential audit by payers. So you want to make sure if it happened, it's documented and it's available if the payer were to ask for that record to, again, demonstrate medical necessity and that the reimbursement was appropriate. Okay, leaving plaque behind, let's talk about ischemia. So a little bit different criteria. I want to save time for questions, so I'm not going to go through every detail here, but just like the plaque coverage guidelines, there are things that the payer wants to see and things that they don't want to see in order to cover the analysis. So some really exciting updates, again, from the Cleerly market access team, who has made just the most incredible strides over the last few years, and especially in the last 6 months. So very, very happy to, again, say that Medicare does have established local coverage determinations covering the Cleerly analysis test based on the criteria we just discussed. So those Medicare administrative contractors are CGS, NGS, Noridian, Palmetto, and WPS, which make up the majority of the United States. So that is huge and very, very successful for the company and for the test. And then there are 2 Medicare administrative contractors who have not yet published any LCDs, which is First Coast and Novitas. But keep in mind that in absence of a coveraged LCD, doesn't mean that it's not going to be covered. It just means that those claims are essentially reviewed on a case-by-case basis. So it's not a bad thing, but something we want to make sure you guys are aware of if you're in those jurisdictions. And then again, some really huge wins on the commercial coverage side, most notably in the last 6 months. So there's coverage under Humana, Cigna, UHC, Evacor, Kansas City Blues, Excellus, and most recently Aetna. And again, this is fantastic, and no surprise, those coverage policies essentially mirror the coverage criteria that Medicare has established. So same coverage criteria and same exclusion criteria as well. And again, these are the biggest commercial payers that exist. So this represents quite a large portion of the commercial payer covered lives in the United States. All right, so I know we have some questions coming. I'm going to wrap this up. I'm going to stop sharing here.
Great. Thank you so much, Alyssa and Ahmad. That was really, I got a lot out of that. I didn't understand much of that, even though I've been ordering and reading and doing cardiac CT for 20 years. So super helpful. And yeah, let's pull up some questions from the audience. I can't see any on my screen yet. Ahmad, can you see some of the questions? Oh, here's one. Sorry, now they're coming through. What does qualifying and non-qualifying mean? I don't know who wants to take that one.
I'm happy to, unless Dr. Ahmed wants to step in. So basically, there's these advanced payment models under the Medicare program, and physicians are able to elect to participate or not. Really, to just dumb it down, it's a program where you're incentivized to provide data on quality and outcomes. And if you participate and you meet certain metrics under the program, you're qualifying to get this little tiny extra payment. But again, as Dr. Slim mentioned, might be pennies for a single claim, but if you count all of the claims that are submitted in a calendar year, that could be quite a substantial incentive to continue to participate and to meet those metrics. So if you're not aware that you're participating or qualifying, you're probably not getting that qualifying payment. Dr. Slim, anything else I missed that you would like to clarify?
No, that's pretty much it.
Perfect.
Okay, great. Here's another question. Can you explain how global fees work for plaque analysis and FFRCT, and how hospitals typically split reimbursement between physicians and technical components on the back end? Is that one for you, Dr. Slim?
Sure. So the way that it happens is, and I know there was another question too about can you do it without ordering the test? So just to kind of simplify it as much as I can, you need to order the test. So CCTA is done. You have to have the result to be able to order it. You have to know if it is CADRAD 0, 1, 2, or 3, right? To avoid the exclusionary language. Once you have the test result, then you have to have a conversation with the patient, and then each test is ordered separately. So far, we have 2 separate codes for ischemia or FFR and for plaque analysis. Both separate orders will have to be placed. They will need to be authorized so you can ensure coverage. And then they get reported, and then they get reimbursed on the back end, assuming that all the criteria for coverage has been done. Now, how is it done on the back end if a global component is done? When you get your productivity report from the hospital, they track that global component. And for the assignment of productivity, you get assigned the work RVUs component of that global. So even though the hospital system goes and builds the global component on the back end, they have a breakdown that's published by CMS of what work RVUs is assigned to the professional and work RVUs for the technical. and that professional component goes back to you. The hospital bills for it in the back end. Now, if you are someone that does not work for the hospital, but you perform it in the hospital, even though the global component goes in, you submit your claim for the professional component, and then you have to have a discussion with the hospital system how you want to do it.
Great. And a question, but I think you just explained this. To confirm, plaque and FFR can be ordered simultaneously as long as the criteria is met. I think you
You
guys
just
both
have
laid
to
out.
drop,
Yes.
you just have to drop two separate orders, but the answer is yes.
Yeah. And I was impressed that CAD-RADS 1, so CAD-RADS mostly based on stenosis severity. So CAD-RADS 1 is the criteria for plaque. So that's anything greater than a 1% stenosis.
Correct.
Were you surprised by that? Is that?
No, so when this went on for reimbursement, we had to have a lot of meetings. Societies were there, SCCT was there, and we had to engage with the different regions. And we did explain to them that really, at the end of the day, non-obstructive disease is not benign, and all degrees of non-obstructive disease, depending on the volume and the quantity in the plaque, can translate to anything. And there is variance among the readers. So we were able to garner support for CAD-RADS 1 all the way to 3. And now understanding CAD-RADS 4 is going to need intervention, so the payers and the MACs were not enthused to cover it because they're going to get an event anyways through the intervention.
Great.
Yeah, I
And
just
I think,
to
go ahead.
oh,
Go ahead.
thanks so much. I just wanted to also mention one other caveat around billing of both the new CPT code and the existing ischemia code. So in 2026, one big change I did not mention is that there are no longer any edits in place that restrict billing the ischemia or plaque code on the same date of service as a CCTA. That was not the case in 2025. There was this edit in place that required use of a modifier 59. That has since been removed. So in 2026, we've seen and we expect to see claims with both the CCTA and one of the Cleerly codes be paid without requiring a modifier. So again, huge win for the Cleerly team, and a huge win for our billers and coders that have struggled through that over the last few years. So I just wanted to mention that. And then I saw another question about coverage in Florida. So as I mentioned, First Coast, which is the Medicare administrative contractor in Florida, has not yet published a local coverage determination outlining coverage for Cleerly. So it sounds like this provider is having some coverage issues. My recommendation would be to appeal and highlight coverage in the majority of the rest of the United States, what that coverage criteria is, and how your patient essentially meets that criteria. But I would say, as a market access team and organization, typically with the development of a new category 1 code, as well as such positive coverage with the other Medicare administrative contractors and the commercial health plans, the expectation is that Florida will come. It's just a matter of when. So appeals are really important to help fight and educate payers kind of at the bottom up. And then the Cleerly coverage team, who again is just amazing at getting these things done, is working with Florida at the top down to make that happen for you.
Great. Thank you. Here's an interesting question. Why no known coronary artery disease as a criteria? This implies there cannot be a follow-up plaque analysis done for, say, 3 years out to compare plaque profile on the same patient. And I think that's a good point, because one of the things we're advocating, I showed you that slide that showed kind of the different morphology of plaque and different composition. And we believe that by treating aggressively, you can transform the plaque from a more high risk or vulnerable to less high risk and a more stable plaque. So yeah, we may have trouble. I don't know, Dr. Slim, do you want to take this? We may have trouble if we know they have plaque, getting a follow-up or a compare study, as we call them. We do them side by side. What do you think about that?
There are some some impact to that statement and why it was picked that way. If you remember the first slide that I highlighted, there's always a balance between the consumer needs and the cost that comes with repeat testing. So payers are always hesitant to endorse anything that requires repeat testing without significant data backing up that doing repeat testing would result with um, overall benefit and value-based care. They know that once they open the door, the floodgates will follow. So you're going to see payers very hesitant to support not necessarily just this product, but any product without significant backing that it would lead to change, not just in outcome, but in cost saving in the long run. The second part, when we start talking about prevention and we talk about follow-up testing as it relates to prevention, it becomes even more complicated as opposed to intervention. Then we really have to, we end up falling in a completely different category that's heavily underpaid and under reimbursed in the United States. And that's a whole different topic.
Yeah, great. Got to get what we can while we can, right?
Yep.
Here's another question, and this is kind of for the readers. Am I guaranteed to qualify for a professional fee for both plaque and FFRCT or ischemia, provided the exam qualifies? I was told there is no professional fee paid for those exams.
That is not true. So, but depends on the hospital system that you work within. I'm assuming it is a hospital system. Because what ends up happening is most hospital system, they go back 1 year and follow an old register as opposed to the new register and the new approved CPT codes. Their automatic system for assignment of production is based on whatever register is fed into the electronic medical records that does the billing. So if they're utilizing temporary codes, part of the register system that they fed into the electronic medical record, they're going to tell you that you don't qualify for anything because it does not translate to work RVUs within their system. So that's a local problem. I would just advocate strongly that there is assigned work RVU and you need your production to be assigned to that work RVU. There is no reason to withhold what you have earned for the services rendered.
Great. Let's see if we have any others here. Can a single order include CCTA with plaque analysis when indicated in both CPT codes? Do payers care what the original order looked like in the EMR? I think you've addressed some of that, but any additional comments there?
No, right now we need the CCTA read first to be able to avoid the exclusionary language. So there is no order that would be all encompassing for three components of it. And currently, we don't have a combined order because by virtue of the NCCN edits that Alyssa was alluding to, that limited the performance of some of the studies simultaneously. And again, it goes back to what I mentioned earlier. You need widespread utilization of the same studies being done simultaneously and data on it. So a potential code in the future could be generated to combine services. But if it's not performed, then you can't perform a RUC survey, and if you can't perform a RUC survey, then you can't quantify the services.
Great, great. It looks like we're almost at the top of the hour. I wanted to really thank the SCCT for hosting and partnering with this seminar. Hopefully the audience found it helpful, important stuff, reimbursement and how it occurs, how it works. I want to thank Dr. Slim and Alyssa Foster for all their great knowledge and insights. And also this recording will be available. And I think, was someone going to share an email there?
Yeah,
if
I
there's
can do
more
that.
questions. Yeah, perfect.
Yeah,
Thank you.
so the question was if there are still outstanding questions, what it sounds like there are about reimbursement specifically. We have an email address that we can answer questions for you. So it's clearly claims at the number 4, the word front, sp.com. And we can, I believe everybody's registered has provided their email address. So I believe we can send that to the registration list. So you guys have it.
Great. Any last thoughts or comments from the panel? You
Thank you
guys
all for
shared.
the invite.
Thank you.
Yeah. Thanks for coming. We appreciate it.
Have a good one.